Um, I don't think we can hear you, Dr. Jacobs.
In my audio. That
There you
better?
are.
Sorry.
Yes.
Okay. All right. Good evening. And thank you for joining us at Harvard Eye Associates for tonight's presentation of Harmonious Rejuvenation of the Aging Face by the truly outstanding Dr. Connie Sears. I am Dr. Jeff Jacobs, and these are indeed exciting times at Harvard Eye Associates. We are celebrating both our past and future at the same time. This month marks 50 years of Harvard Eye Associates serving Orange County's eye care needs, and we are indeed so humbled to have earned our patients' trust over the past 5 decades and are looking forward to providing continued excellence in eye care in both the present and the future. It is with joy and humility that I introduce Dr. Connie Sears. We are thrilled that Dr. Sears chose to join Harvard Eye Associates after completing her training at the top ophthalmology and eye plastic surgery training programs in the nation. When becoming a doctor after completing college, there is 4 years of medical school. Dr. Sears went to the best, Harvard Medical School in Boston. After completing medical school, there is a residency to choose from where you concentrate on your specialty. Dr. Sears chose to do her ophthalmology residency at Stanford University. After residency, to further her expertise in eye and facial plastic surgery, Dr. Sears returned to Southern California to do a 2-year fellowship at UCLA with the world-renowned surgeon, Dr. Robert Goldberg. I was fortunate to have trained with Dr. Goldberg over 25 years ago, so having Dr. Sears join us in practice is so gratifying and carrying on the UCLA tradition. Dr. Sears was able to work with and learn from the top surgeons in Los Angeles these past years, and it is an honor to introduce Connie Sears to present on the newest and most natural techniques for facial rejuvenation. Dr. Sears.
Thank you so much for the kind introduction, Dr. Jacobs. I'm thrilled to be here today to talk to you all. Thank you so much for lending us your evening. And today I want to focus on kind of bringing together rejuvenation of the aging face, and we'll talk about what I mean by harmonious. I'm going to discuss both surgical and non-surgical approaches to facial rejuvenation. And so without further ado, Dr. Jacobs already kindly introduced myself, but so let's dive into it. So I'm going to give a really brief overview about facial aging and really what happens. There are multiple things that are occurring in tandem as we age. There is facial bone resorption and changes, and that is really the structure of the foundation of our face and where our soft tissues sit. And so we also have volume loss. Not only does our skeletal muscle atrophy, but we also have atrophy of the superficial and superficial and deep fat layers. We have soft tissue descent and skin changes that occur related to thinning of the skin, loss of elasticity, and wrinkles that develop. This is Dame Maggie Smith, and so on the left you see a photo of her when she was very young, and on the right you see her toward the latter stages of her life. And these two photos really exemplify a lot of the changes that occur as we age. So when she was younger, you could see she had really high brows, this beautiful periocular fullness that's very youthful, high full cheeks, full lips, and a really nice sharp jawline. And as she aged later in life, she developed some temporal hollowing that is very common. The brows started to descend. There was periocular volume loss, which we can see kind of under the brow. We call this the superior sulcus here. She has skin thinning and laxity with wrinkling. There's decreased lip volume, so her lips look a little thinner. And then there's this gelling that occurs with the soft tissue descent, as well as neck laxity. And so all of these changes together are, oh, I'm so sorry, my light just went out. All of these changes lead to a transformation of our facial configuration. When we're younger, we have more of an inverted triangle configuration, and as we age, we develop more of a rectangle with fullness along the jawline and development of jowls later in life. So, when determining how to address these aging changes in our patients, um, we want to come up with an optimal plan for each individual patient. And this plan for facial rejuvenation really needs to be tailored. There's no cookie cutter approach to rejuvenating the face. Everyone ages a little bit differently, and some, have more soft tissue descent, others have more skin laxity. Usually we have a combination of all of these changes, but when deciding the optimal treatment plan, the number one priority for me is always patient safety. Every surgery, every procedure has its risks. And so we have an extensive discussion with patients to discuss, the risks and benefits of each procedure, what they can expect to see after having each procedure, and so that they can really make an informed decision about whether, the benefit outweighs the risk for them particularly. And then my second priority is to provide a natural appearing result. The last thing we want is for someone to look, done or like they've had surgery. We want someone to look like a refreshed, rejuvenated version of themselves and to maybe shed a few years off. But, really, if I always tell my patients, if you look like you've had surgery, then we've failed. That's really not what we're trying to achieve here. So when thinking about non-surgical options of facial rejuvenation, there are three main categories that I'm going to discuss today. The first one is neurotoxin, or also known as a neuromodulator. And the second is dermal fillers, which there's been an explosion in injectables, and there are a plethora of different products that are being marketed or approved by the FDA, and some are not approved by the FDA. And that list continues to get longer and longer. And then there are biostimulators, which we will discuss briefly. In terms of the neurotoxins and neuromodulators, there are actually several on the market that are FDA approved in the US, and these are listed in the order that they were FDA approved. They all work, although their chemical components are a little bit different. They all work virtually by the same mechanism, which is to essentially temporarily paralyze the facial muscles. And so when we think about what that means, what are we trying to target with the neuromodulator? We are trying to target what we call dynamic wrinkles. And what that means is these are the wrinkles that you develop as you are emoting, versus static wrinkles, which are wrinkles that have developed and etched into your skin essentially after years and years of emoting and using the muscle in the same way. And so when we use a neuromodulator, the dynamic wrinkles are targeted. The static wrinkles do soften a bit, but I do caution my patients, all of your wrinkles are not going to go away. There are specific places where we use neuromodulator because in other places they're a higher risk. And one thing to keep in mind is if you look at the anatomy, you always have to have the anatomy in mind when injecting neuro toxin. And so if you look at the forehead, for instance, this muscle is called the frontalis, and it's a vertically oriented muscle. All of the wrinkles that you develop are actually perpendicular to the muscle action. And so, for instance, the forehead muscle or the frontalis is a vertically oriented muscle, and when it contracts, it forms horizontal wrinkles. And so these are some of the wrinkles that we are targeting when we are injecting neuromodulator in the forehead. But we can also, target the what we call the 11s, so those frown lines that you develop. The crow's feet, which is the orbicular. This is kind of a sphincter of a muscle so that the wrinkles are perpendicular across the entire muscle. These are the bunny lines, so we can inject the nasalis here. Sometimes we inject the muscles that depress the corners of the mouth, and we can also inject the platysma, which is a sheet-like muscle across the neck that forms what we call platysma glands. There are also different, things that are being, they come and go in popularity, like the lip flip and other injectables, or like the Botox rhinoplasty. But we won't be discussing those in this talk. The other injectable are the dermal fillers, and these are used for soft tissue augmentation. And this is really to combat that volume loss that we experience with age. But in using these, it is really important to keep the complications in mind. There are a long list of complications that can occur with dermal fillers. And the most dreaded complication really are related to vascular compromise or occlusion of a blood vessel, which means that the filler itself somehow makes its way into the blood vessel and can lead to blindness, even stroke, and tissue necrosis, or the skin losing its oxygenation. But fortunately, these risks are exceedingly low, but if it happens when there is vision loss, it can be permanent and it can be a very dense vision loss. Other things that can happen with dermal fillers and things that I see quite frequently actually are swelling. That kind of comes and goes or lingers, a sort of a bluish discoloration of the skin that we call a Tyndall effect, and that tends to be under the eyes if you're injecting the lower lid hollows, and lumps and bumps. And we'll talk about that in a second. The other thing that I do see a lot of is either overtreatment or undertreatment. And in terms of overtreatment, what happens is you change or distort your facial anatomy, and so that it no longer looks like a natural filling effect. And so there are a couple of different categories of fillers. There are non-dissolvable fillers and dissolvable fillers. And in terms of the non-dissolvable fillers, these tend to be products that, once we inject, we cannot dissolve. And the first two listed here, hydroxyl apatite, which is Radiesse, or PLLA, which is Sculptra, are actually technically biostimulators. But there's also Belafil and silicone. Silicone has really fallen out of favor because it was used decades ago, and it tends to migrate and expand over time, and it's incredibly difficult to remove once that happens. So I've seen patients with really distorting defects after they had silicone injected several decades ago, and it just continuously expands over time. In terms of the dissolvable fillers, there are the hyaluronic acid fillers, and again, this is really where the market has expanded and really exploded. We actually have hyaluronic acid naturally occurring in our body, and these hyaluronic acid fillers have different properties that make them, really dense, so that they stay in the area that you inject them. And some of them are more dense, so less likely to migrate. Others are softer, so that they feel more natural. But if we have any issues with them, we can dissolve them with an enzyme called hyaluronidase. And this includes, whether someone has a reaction to the filler, whether there's an asymmetry or lumps and bumps that someone is unhappy about, or even if there is, again, that dreaded complication of an occlusion leading to like blindness or skin necrosis, we can inject the enzyme and dissolve all of the filler. And so usually the treatment areas that we target with dermal fillers are lips. The lips lose volume, and we actually don't need very much volume at all to inject to restore that natural fullness that is present in youth. But mid-face augmentation is one of the most common filler locations, and as well as the tear trough and the nasolabial folds. A couple of things to keep in mind, as with neuromodulators, but even more importantly with dermal fillers, it is critical to keep the anatomy in mind. And in knowing the anatomy really well and knowing what the danger zones are, you can try to prevent these risks or these complications from happening. And also, you can, by knowing the anatomy, inject in a way, in a three-dimensional way, to try to restore that natural fullness that was lost from youth. And so the other thing I do want to mention is that the eyelid skin is the thinnest skin in the body, particularly in the lower eyelid, right in the inner corner where the tear trough is. That skin is very, very thin. And so it is not uncommon to see a lot of lumps and bumps in this area because this skin is so thin, it's not very forgiving. So if the filler is not injected in the correct plane, it actually becomes very obvious, or it produces that Tyndall effect that I've mentioned. In terms of surgical facial rejuvenation, this is really an option when the injectables aren't quite able to produce the improvement or the change that a patient is really looking for. And this tends to be more of an aggressive rejuvenation. Usually, what I discussion I have with my patients is, the neuromodulators and the dermal fillers and the biostimulators can accomplish so much. Usually it's anywhere from a modest to a really moderate improvement depending on the age, the amount of soft tissue loss and descent, and really what the patient is trying to accomplish. But there does come a time when the fillers and neuromodulators can't really accomplish the changes that we're hoping for. And particularly that is true for when we have a lot of soft tissue descent. The fillers and neuromodulators are not going to elevate that tissue back where it was in youth. And so when considering periocular rejuvenation, we have to keep in mind that everyone's anatomy is a little bit different. And so in terms of upper and blepharoplasty, I mean, I can talk about the different aging changes that happen within the eyelids and the periocular region in a whole different talk. But just to briefly state, everyone ages a little bit differently. So the brows, as we discussed, descend a little bit. You have this lateral hooding, and the lateral brow tends to descend a little bit more than the central brow. And the reason is that frontalis muscle that we discussed that is vertically oriented only comes to about this area. And so the rest of the brow doesn't have that much support. And so it tends to droop faster than the medial aspect of the brow. And so that causes this sort of hooding of the soft tissue here. And when doing an upper lid blepharoplasty to remove this redundant skin, we really keep in mind strategically placing the incisions so that we can hide the scars. There's no such thing as a scarless surgery, but we can do our best to place the incisions in areas that are really hard to see once they're healed. And so that's true of upper lid blepharoplasties, and even more so for lower lid blepharoplasties, where we can do a transconjunctival approach, which means we go from the back side of the eyelid so that there is no incision on the skin. However, if the patient has a lot of redundant skin, or the skin is very loose without a lot of elasticity, then we do have to make an incision right underneath the eyelashes to remove that redundant skin. And that incision heals actually quite beautifully. It's almost not noticeable at all because the lashes hide it quite well. And in terms of the lower lids, we have, different things that can happen, like fat herniation, where this bulginess, which, some people call lower eyelid bags, is actually fat herniation that was previously within the orbit that prolapses once the tissues holding it back kind of become more lax. And so what some people notice is this development of a hill and a valley configuration. And so you have volume loss in the osteocutaneous ligaments that are forming this type of morphology. And so different ways to address that is to use the fat to our advantage and kind of drape it over like a curtain to recreate that smooth junction between the lower eyelid and the cheek. The other option, of course, is to remove the fat and then to remove the excess skin, because I always tell my patients, if we remove the fat and we don't do anything with the skin, it will look kind of like a deflated balloon. And so, again, lots of different ways and nuances to periocular rejuvenation. In terms of the addressing the brows, brow descent can be addressed in multiple ways, and it really depends on patient selection. So for instance, my favorite approach is an endoscopic brow lift because we can, again, strategically place the incisions in the hair-bearing scalp so that they hide really nicely. And so usually we use multiple incisions to form a flap and elevate the entire flap up to bring the brows up. And we can accomplish a really nice lift endoscopically where we can minimize the amount of scarring. Now, this isn't an option for everybody. If someone has a longer forehead or really bowed forehead, it really makes it difficult to do that approach. And so other options are what we call a pretrichial brow lift, where we make the incision just in front of the hairline, um, and that can hide really nicely in people who have a full hairline. And then the other incision that we use somewhat commonly is a direct brow lift, though we keep it more laterally because the more medial the incision is made, the more obvious it's going to be, and this area doesn't heal very well. A mid-forehead brow lift is used very infrequently, but in special patient circumstances, they might be good candidates for that, and it would really provide a nice lift. And the corona brow lift has really fallen out of favor because of the morbidity that comes with that. And again, we can accomplish a really nice lift from an endoscopic approach that is much more minimally invasive in a way. Um, in terms of facelift or a rhytidectomy, we have to keep in mind that, again, the soft tissues are aging in multiple different layers. And in order to address that, we have to keep the anatomy in mind. The incisions are usually hidden really nicely within the hairline and then in front of the ear and kind of behind the tragus, around the ear, and then back into the hairline. And there are a couple of different approaches. You can do a skin-only facelift, though that tends to not last as long because the skin stretches and it becomes more loose again. So if you really want to achieve a longer lasting facelift, you really have to consider addressing this mass either by doing a mass plication, which means we fold this mass onto itself, or removing a piece of this mass, or diving deep under this mass, which is called a deep plane facelift. And this is probably the most robust approach, and you can extend that, called an extended deep plane facelift, into the neck. One thing to keep in mind when doing a facelift, it is not without risks. Of course, in going under this mass, you can expose the facial nerve, and the facial nerve actually provides all of the nerve function to the mimetic muscles of the face. So all of the muscles that move your face and provide those facial expressions move due to the innervation of the facial nerve. And so, one option to avoid the facial nerve is to go through one of the endoscopic eyebrow incisions, but that can only address the mid face. You wouldn't be able to address the lower face. In terms of the skin, so one of the things that we can all do to avoid progressing or more rapidly progressing aging is being careful to to not have too much sun exposure. Photo aging really accelerates wrinkling, loss of elasticity, and loss of collagen. The skin becomes more lax. The skin can also develop a rough textured appearance, and there can be a lot of pigmentary changes with a lot of sun exposure. On the right, this is a famous photo of a truck driver who spent decades driving in for work, and so he had extensive sun exposure just to the left side of his face, and you can really see the change in the skin from the left side that was chronically exposed to sun all day compared to the right side. Of course, he still has aging changes on the right, but they're much more severe on the left. In terms of addressing the skin, we can do things like skin resurfacing with a CO2 laser. This is essentially causing a large second-degree burn across the entire face. And previously, the CO2 lasers were very aggressive. They were uh, they essentially ablated the entire epithelium or the top layer of the skin. And more recently, we are using lasers that have kind of intervening spaces of lasered skin and non-lasered skin. And so we really rely on what's called a pilosebaceous unit, and which is contains a hair follicle, and we rely on that to essentially provide a progenitor for the new epithelium to form. The face has 30 times more pilosebaceous units than the neck or the chest, and 40 times more than the arms and hands. And so we can do a really deep peel of the face compared to the neck, and to get a really nice resurfacing of the skin. There are some medications that suppress pilosebaceous units, and so it can become pretty risky to do a CO2 laser on someone who's on Accutane, for instance, or someone who has a collagen vascular disease like lupus or scleroderma who will not heal as well. It can be pretty risky to do a CO2 laser on those individuals. In terms of contraindications for the CO2 lasers, keloid formation, because again, you are forming a very large wound on the skin. People who have conditions where they don't heal very well, if someone has active rosacea or acne, vitiligo, lichen planus, or psoriasis, or any active cold sores. Complications of lasers can also be pretty devastating depending on whether you've gone, pretty aggressive with the laser. For someone who has more pigmentation in the skin, there's something called post-inflammatory hyperpigmentation, where you can have these sort of patches of hyperpigmentation after having a CO2 laser. This complication tends to be long-lasting, but it does tend to get better. The more dreaded complication is hypopigmentation and scarring. Hypopigmentation, once that happens, tends to be permanent. And so if someone has more pigment or more melanin in their skin, we really have to be careful about, first of all, they might not even be a candidate for CO2 laser, but if they do a CO2 laser, we have to be very, very careful and not be as aggressive with it. The CO2 laser can cause scarring if the laser is done too deeply, or if an infection develops. You can also develop eyelid malpositions where the skin tightening actually pulls down the lower eyelid, which I see somewhat frequently. And of course, if you've had cold sores before, the CO2 laser can reactivate them. So in terms of coming full circle and thinking about what the word harmonious really means, um, when we are considering the optimal rejuvenation for an individual, you have to take all of the components in mind. You have to keep in mind the facial bone resorption and those changes, the volume loss that has occurred with the skeletal muscles and the fat atrophy, the descent of the soft tissues, and the skin changes. And so ways in which we can address each individual one with the bony changes, we can address that somewhat with a deep filler, not entirely, but we can improve some of that structural component a little bit. In terms of volume loss, the ways that we can address that is to use the fillers in a superficial and deep manner in sort of a 3D injection pattern. And we can also consider autologous fat transfer, where I would do a little bit of liposuction in the belly or the thigh to transfer some of that fat, to use your own tissues instead of a synthetic material to fill in the volume deficit that has developed. And I usually tell my patients, I'm not contouring your belly. If we do it correctly, you won't even notice a difference in the belly. I just need very small volumes to address the volume deficit that occurs with time. And in terms of the soft tissue descent, we can do things like radiofrequency microneedling, which I didn't discuss in this talk. But that's really when surgery comes into play, and we can address the descent by, doing a brow lift or blepharoplasty, facelift, and neck lift. And then again, in terms of the skin changes, we can consider chemical peels to smoothen out a lot of the texture changes and pigmentation changes and soft wrinkles. And then if you want to be a little bit more aggressive, to get a more robust response, you can consider doing a CO2 skin resurfacing, and some of the light therapies also help as well. And so, um, considering everything together, if you address one component, for instance, doing a facelift to elevate the soft tissue descent, but then you don't address the skin changes, you won't have the optimal outcome for your rejuvenation. And so keeping all of this in mind and really addressing each component of aging would result in the most optimal outcome. Other things to consider, which I didn't discuss in this talk, is exosomes, antioxidants, growth factors, and algae. There are, again, a lot of developments in the anti-aging products that are available. There's not a lot of research done, or any proof that scientific proof that any of these work, but I know that these are growing traction and getting more and more popular. So I'd like to thank all of you for giving me your attention on this lovely evening. I'm really thrilled and excited to join the team at Harvard Eye Associates, and happy to answer any questions.
Thank you so much, Dr. Sears, for your time tonight. I thought it was very educational. I'm very happy all of the patients got to learn from you. And thank you, Dr. Jacobs, for joining us to introduce Dr. Sears. We feel so grateful to have both of you in our oculoplastic sector. So if you guys have any questions, please feel free to leave them in the chat, or you can email them to marketing@harvardeye.com. We're more than happy to send those to Dr. Sears' way. And we hope you enjoy the rest of your Thursday night. Thank you.